Assalamu alaikum, good evening, and welcome to this presentation around how health professionals can manage Ramadan for those people who are fasting with chronic conditions. My name is Salman Wakar. I am a GP and an academic, and alongside Nazim, who's my co-host today, have been involved in creating some guidelines around Ramadan and various different health conditions. I'm also the former president of BEMA and have been involved in a lot of this work in terms of its policy and practical implementations as well. But here today, I'm talking to you as a peer, more around how you manage your Ramadan conditions for your patients. For those of you, if you have any issues, technical issues, please use the webinar chat function for any of those, and inshallah, we'll be able to uh, overcome those. We also have a webinar Q&A function. So if you have any questions throughout the presentation, we encourage you to use that just so it helps us manage the queries as and when they come in. I'm just going to let Nazim introduce himself and then we'll kick off, inshallah. We're hoping for the presentation, including question and answers, to take an hour. So we hope to be done around 8:30. So Nazim, over to you.
Assalamu alaikum. Jazakallah khair, Salman. So, as Salman mentioned, I'm Nazim Gary. I'm one of the consultants in diabetes at the Queen Elizabeth University Hospital in Glasgow. I'm also an honorary clinical associate professor at the University of Glasgow. And really, since the pandemic, when Salman and I kind of first interacted, we've had this kind of vision about having guidance on management of health in general in Ramadan, not just initially diabetes, which a lot of the guidance was on, but other conditions as well, including frailty, old age, as well as acute illness. So the compendium has went from a rapid review to a compendium, and from the compendium, which inshallah someone will tell you a bit more about, we've been able to kind of come up with some guidance and have some scenarios to show you how to navigate the compendium.
Thanks, Nazim. And just so you know, this is being recorded, excuse me. So if you do miss anything, the slides will be in the recording. And this is also something that you can share with your colleagues as well. So don't feel the need to take notes or anything as the presentation goes on. So Bismillah, let's begin. And I think it's important when we begin, we are trying to present to you the evidence base as we understand it in evidence-based medicine in the Western sense of it. Because all too often, when it comes to these types of things historically, it's been very much eminence-based. It's been based on opinion, in that someone saying that I heard so and so say that such and such person, if they have such and such condition, should or couldn't fast. And what we try to do is look at the evidence base, but we have to recognize that the evidence base in this field in Ramadan is still very novel. Apart from diabetes and possibly chronic kidney disease, we haven't really got high quality randomized controlled trials that we can lean on in the same way that we would do with our existing guidance in NICE and SIGN and many other things that we use. And they're also done in contexts that aren't in our Northern European populations in terms of climate, in terms of wider culture as well. And of course, the quality of them hasn't been necessarily to the standard that we would want to see in our, or expect to see, I should say, in our mainstream guidance from our professional societies and so on. And there are many reasons for that. But we take that into account by looking to take the views of experts. And you'll know that expert synthesis is actually the lowest rung of the evidence ladder. So when you get experts together and to come to a consensus, that actually forms a body of evidence. And for those of you who don't know, many of the guidelines around monitoring frequency, for instance, someone says check LFTs every 4 to 6 weeks. A lot of these guidelines are actually based on evidence synthesis as opposed to someone doing an RCT about it. So we use it in a day-to-day practice very frequently. So we used that. We took that approach during COVID to put together the compendium, which we'll come on to in just a moment. And so the compendium is essentially a guidance. It's a guidance document which is evidence-based. It's based in peer review consensus statements as well around whether or not a person should or shouldn't be fasting. It's meant to guide you. It's not meant to be authoritative. So it's not in the same way that you would use a NICE or SIGN guidance or your hospital guidance or your trust guidance or your ICB guidance, for example, health board guidance. It's meant to be something that is used to facilitate a patient-centered, evidence-based, individualized decision, right? Because the final decision as to whether or not someone fasts rests with the individual. However, you should be reassured that the evidence that we present to you has, in nearly all the sections, been published in credible peer-reviewed journals. And this includes journals like the BMJ journals, Lancet journals, and many others. So we're very certain that what we're putting forward to you are things that other colleagues would accept as a standard of care to provide. And this isn't just the UK context. These are also co-authors of ours who've been taking part in many other countries, including in Muslim majority worlds and in Muslim minority contexts as well. So we also just need to talk about this idea of what is where does the religious jurisprudential or fiqh views fall into this? And it's important that we, as clinicians, stay in our lane. And our lane is that we are the experts of medicine. And so when it comes to issues about whether someone should or shouldn't fast from a religious point of view, these are issues that we will have to defer to the religious authority. And of course, for an individual, they may say that I need no religious authority because that's their view of Islam. Um, or they may say that I am the religious authority. I choose to take that upon myself. We wouldn't necessarily get involved in that conversation. But we also must recognize that differences of jurisprudential views exist. And these will vary from some people saying that a certain route is permissible or a certain type of condition does or doesn't exempt someone from fasting. So you have to take all of that into account, but focus on the medicine. And what we're presenting to you here are our personal professional views, and they wouldn't substitute for the professional advice that you would be giving to your patients, which has to be individualized to them in the context of your professional conversation. Now, there are two main resources that we're going to be using. One is the Ramadan Compendium, which the link to it is there on the screen. We'll also show you a QR code shortly. And alongside that, there's going to be a BMJ evidence, a BMJ practice pointer, which is actually quite a helpful thing for you to have on. It's got in there a really nice infographic, which you can download and put on your desktop or your laptop. If you're unfamiliar with doing Ramadan-based consultation, and particularly to colleagues who are not Muslim or don't look after patients frequently, it's actually quite handy because it goes through everything really nicely for you. Um, and as we mentioned before, it doesn't form a directive, but that's the QR code that you would want to use to get the compendium on your desktop. So as we're doing these slides, as we're doing the case study shortly, if you have got a second device, just quickly take a screenshot of that and load up the compendium because that will help guide you and help you understand how you do this in your day-to-day clinical practice. And when you do click on that link, this is what you'll see. You'll see a page which has got several different conditions in it. Now, I'll say it's not the most ergonomic document. We're working on that, inshallah. Give us another year or two, and hopefully it'll be a much nicer looking document. But you'll see it's quite comprehensive. It covers not only the general principles, it talks about acute illness, vaccination, decision for chronic illnesses, and then lots of other conditions, including occupational health and mental health in there. But the key thing that colleagues will be wanting to look at is something that's quite easy to work with, which is a table, right? Everyone likes to look at a table and work off a table. And what we do is that we put this in a very relatively easy to use form at the in the compendium, which actually risk stratifies patients into different disease categories for excuse me, into different risk profiles for different diseases. So here, for example, in the case of cardiovascular disease, you can see that traffic light system about what is red, amber, and green, and different disease statuses put into there. But before we go into the meat of it, I just wanted to take one step back and just think about what exactly it is that we're dealing with. Now, I'm going to assume that most people in this room know what Ramadan is. So forgive me if anyone doesn't. I'm working with the assumption that you know what Ramadan is and you understand why the importance of it is. But we need to know that what we're entering into now are areas of shorter days. So as the Islamic calendar is a few days out of sync with the Gregorian solar calendar. For the next few years, well, quite a few years actually, the days of fasting will be getting shorter and shorter in the UK. The converse will be true in the Southern Hemisphere. So right now, alhamdulillah, as we start our fasts, we will actually be having relatively shorter fasts, and that will keep going up until 2031, which is when we will start having the shortest hours of fasting in the Northern Hemisphere. Right? 2030, by the way, is the day when Ramadan actually starts at Christmas Day, which would be very interesting for other reasons. But that cycle will continue over 33 years as the months overlap over each other. And this is an important consideration because, insofar as other guidance that exists, it hasn't really been a consideration about acclimatization or consideration about where and when you are fasting. Because obviously, regardless of whatever health conditions you have, if you are fasting where the average fasting hour is 12 hours, 10 hours, 8 hours, it's going to be very different from if you're fasting in an area where the fasting hours are 17 hours, 18 hours, 20 hours, or if it's a very hot climate versus a very cold and damp environment. So all of these considerations are incredibly important. And Ramadan, of course, isn't only an issue for us in a sense of Ramadan is a big issue, I should say. It's, 6.5% of the country of the UK is Muslim, and certain cities, we've listed a couple here, but in there you can also throw in Luton and a few others. 30% of the population is Muslim. That's quite a lot of people in a city that are observing this tradition. And ethnically, Muslims are relatively diverse, although two-thirds of us are of South Asian background, but we also have significant pockets of other populations as well. And we know many of those populations have got an increased possible racial, possible other factors in there as well, but an increased prevalence of diabetes, type 2 diabetes. And we also know from the data, particularly South Asians, that that rate control isn't getting better. And that's a global issue, not just specific to us in the West. But we also know that globally 90% of Muslims fast. So this is going to be an issue that as we medicalize more and more, as we're seeing greater life expectancy gains, as we're seeing new drugs come in, and we'll talk about some of those in a moment, you're going to potentially see this being more and more of an issue. But I also wanted to touch on the fact that Ramadan also presents a significant opportunity for us to intervene positively. So if you're talking about populations, but again, particularly in the West, where you have got higher rates of cardiovascular disease, metabolic disease overall, type 2 diabetes, and cardiorenal, all these sorts of problems, chronic kidney disease, high rates of smoking, obesity, and so on. Here you have a population, a significant number of populations. I said 90% of 30% of Bradford is going to be observing this fast. Have we ever thought about how we design our services? So whether in the acute sector, in the community sector, have we thought about how we are adapting to this reality and how are we adapting in a positive way so that we can actually approach our communities in a way to actually activate the health benefits that Ramadan can bring. And maybe we can talk about that at the end in the questions. Now, when it comes to actually doing a Ramadan consultation, the principles behind it are quite straightforward. You'll take a history in the same way that you would do. But you focus on the drug history and think about particularly chronic pain. And again, we'll come back to why that's important in just a moment. I talked earlier about the importance of previous experiences. Now, other people, when they've talked about Ramadan fasting, it's again been a very binary choice. It's important for us that we individualize it as much as possible. And we understand about the person that we're dealing with. What was your previous Ramadan like? Because it's going to be very different if you're talking to someone who has fasted their entire life and has managed to overcome many hurdles versus someone who is either a new Muslim or someone who has had a rather difficult time in previous fasting, even if they have other conditions. And what lifestyle changes have happened since their last fast, and what lifestyle changes do they have coming up in the Ramadan to come? And that includes things like what work they're doing, any childcare commitment, or other elderly relatives that they may have to look at, or anything else that's important to them. We need to discuss that because that will affect and influence their tolerability and their enthusiasm for fasting this upcoming year. And the key takeaway from all of this, the one thing that we want you to take away from all of this, is that you must risk stratify the patient, right? And that risk stratification is the novel thing that we need to put out here. And it's not only for diabetes, it covers all conditions that the person has, right? If the risk is moderate to low, i.e., green, you'll usually just adjust medications if you think about some sick day rules if you need to, but generally it's a relatively straightforward thing. If the patient is high risk or they're amber, the advice is not to fast. And if they are at very high risk, if they're in the red, the advice is to not fast, right? That they must not fast. And we'll talk on to the reasons and the differentiation between that in just a moment. And the key thing here is that we must document this. And the whole idea, the whole purpose of this, us bringing this forward, was just giving us as clinicians something to hang our hat on rather than I think so, or so and so said so, or because you're on this condition, because you take this drug, or because you have this condition, you could and you can't fast. This highly individualizes, highly contextualizes, and makes this a highly personally centered conversation as well. And we just wanted to touch on a couple of things here around this idea of who may be exempt from fasting. And the Quran has a concept in here, a religious concept, if you like, of sick leave. where Muslims believe that God has said that, Allah desires ease for you, He does not desire difficulty. And there are some conditions that the Quran lays out as to why people would be exempt from fasting. And again, other religious scholars have added other aspects to that as well. And now the idea of Ramadan fasting is that it may exert a degree of hardship, but it shouldn't exert a degree of harm, right? And different scholars have interpreted sickness differently as well. And what we've written here is the definition, as it were, according to the Hanafi school, which is one of their four main Sunni schools. We recognize, again, as I said earlier, that there are many different interpretations, but by and large, they're all very similar, which says that the definition of sickness is that if an ailment is worsened through fasting, especially if it's irreversible, if an ailment is there of which the healing will be delayed as a result of fasting, or if there's a legitimate fear of either of the two occurring, then from a religious point of view, again, this isn't a clinical thing. This is a religious thing for us to have some awareness of. Then the individual may be religiously exempt, right? So we're just delving a little bit into the religious side, but trying to stay in a lane. We're only going to be focusing on the medical bit, but these are the things that will be going on in your patient's mind and also in the religious authority should they deal with one. And what determines expiation is that what prior knowledge and prior experience that they may have. For instance, if they are someone who has got Addison's disease, they know what happens if they do or don't take their steroids. That's going to be very personalized to that individual. And also the opinion of a physician in that matter. And they put Muslim in brackets because, again, different schools of thought will have different weighting that they put on or a different view as to whether or not any physician will do or if it has to be a Muslim physician. But all in all, again, ultimately, the decision as to whether or not a religious authority needs to be consulted is upon the individual. And most importantly, the decision as to whether or not they fast is placed upon the individual themselves. You, as the clinician here, have to do what you do as a clinician, and that is to advise based on the evidence that you have in front of you. And the reason that we have this red, amber, green system here, and the reason that we have a difference between very high risk and high risk, these are actually taken from the International Diabetes Federation's Diabetes and Ramadan guide stratification that they had some years ago. It's not the most recent one, not the most recent classification that they have, but the one that they had prior to that, because we felt that actually that was very portable. It actually made a lot of sense because this actually makes a differentiation between someone who is high risk and from a clinical point of view, you shouldn't fast, right? There's enough going here that tips this into we're not comfortable with you fasting overall, right? But there may be things that you could do that you would fast against medical advice, but this would be done in the same way that you would advise someone who wishes to self-discharge against medical advice, or someone who doesn't want to go into hospital despite your advice, or someone who doesn't want to take the medicine because of intolerable side effects. We do this day in, day out in our clinical practice. But this level of concern that you have for the person isn't as strong as it is in the red. The red is the advice is that you must not fast and you're very high risk. And so there's a higher degree uh, of concern that the clinician is giving to the patient here. And again, there may be conditions, for instance, if the person fasts in the shorter days of the year, or if the person fasts alternate days fasting, or if the person habitually fasts and has got quite a high degree of acclimatization and a high degree of prior experience, they still may be in the red condition and have a strong desire and commitment to fast, and they can fast safely, potentially also being possibly supported by you in terms of monitoring and things like that. But that would be very different from perhaps the majority of individuals who are there. And the reason that we have this here is twofold. One, because we know the default position is any of you who have looked after Muslim patients who wish to fast will know that you're constantly having to convince people not to fast. Right? That's generally the nature of the conversation. Someone comes to you and says that doctor, nurse, pharmacist, whatever, I've got so and so things. Can I fast or not? And you're having to say to them why they shouldn't fast. It is less common, though it does happen. People are saying, I don't want to fast. Is that okay? Right? So there's that sort of framing of it. The other framing of it is that these people also go back to religious authorities. And often what happens is that the religious authorities don't necessarily get the same information that we have given to the patient because they're dealing with lots of information in their head and they're saying, well, I'm not sure what they said and so on. But in this context, in this framework, you have given them a very clear red, amber, green rating. So if the religious authority, the mufti, the imam, whoever it is, is told that I went to my clinician and my clinician said I'm very high risk for fasting, it makes the religious opinion that the individual is given much more clearer or easier for the individual to receive. So all in all, we find that it works quite well. It works quite well in the UK, it works well quite well globally, and it works quite well not just in diabetes and in many other conditions. Right. So what I'm going to do is I'm going to hand over now to Nazim, and we're going to talk through a few cases, and then talk about a few other things as well as we wrap up. Again, just to reiterate, the main aim here is to give you some idea of understanding and appreciation of this. We're not looking to supplant or direct your clinical judgment. You are still making a clinical judgment, but hopefully you're making a clinical judgment that is empathetic, that is pragmatic, and one that actually enables that patient-centered conversation to happen. Um, and it's important, again, as I hand over, that the main thing that you take away is that Ramadan is really important to patients, and that it's really important that you take an objective, evidence-based view on this that is individualized and is person-centered, and you assign risk to patients. It's really important that you assign and assess the patient, excuse me, and you assign a risk to them, and we've got the framework here that will take you through that. So I'm going to hand you over to Nazim. I don't know if you want to make some remarks before you do that first, Naz, but here's the first case if you want to.
Okay, no, Jazakallah khair, Salman. So just want to building on that thing in terms of we're obviously taking a clinician focus as opposed to a kind of religious directive on things. But I accept that there'll be a number of healthcare professionals who perhaps have differing levels of Islamic knowledge and may even be scholars themselves or be students of knowledge. So one thing that I often do to help bring everyone up to the level in terms of the playing field is to help them understand, especially when it comes to non-Muslims as well, when you're trying to explain to them about Ramadan and things, and this concept of harm is on one end, ease is at the other, hardships kind of a bit middle, bit more towards the kind of ease side. The whole point is that for each individual, hardship and harm will vary, and for one individual, it might vary even within the month or from previous months as well. And I often go back to the verse before in Surah Baqarah, which makes reference to the fact that fasting is prescribed, it was prescribed for those before you in order that you may acquire taqwa or God consciousness. There's no actually explicit mention of the word hunger, although fasting obviously involves abstinence from food and drink and marital relations. So the idea is that you're trying to inculcate this concept of putting God at the forefront of your mind rather than at the back of your mind. So if a person's circumstances is such that fasting is appropriate, no, the pleasure of God is to fast. And likewise, if the circumstance is such that fasting may be injurious or be harmful to health, then absence from fasting would be pleasure to God because it explicitly states He doesn't wish you to harm yourselves. So it's sometimes with individuals who perhaps are struggling to perhaps come to terms with the concept of not fasting because of the advice given, is to remind them going back to the original principle and one of the inner aspects of benefits of fasting, that's that God consciousness. And Allah subhanahu wa ta'ala knows that all things equal, one would fast if they had a chance to. So you don't need to worry about it. He doesn't forget. So it's about sometimes helping the individual who's undertaking fasting understand the purpose behind fasting and to put God at the front of their mind. It can sometimes help with that acceptance of the fact that perhaps at this point in time, fasting in Ramadan consecutively may not be the safest or best way forward. So just before we go into as we've gone into the case studies, I think the most important thing is that we have to be empathetic and sensitive to the patient's needs. And also for some conditions, giving safety and sick rule advice. And the way I would explain, for example, fasting is like, for example, somebody comes to you and they're looking to take on a new hobby, a sport, they're shift working, similar idea. How would you approach that patient? Ramadan is no different. Sometimes we kind of separate Ramadan from everything else, but no, someone could be looking to take on a new job which involves night shift as opposed to day shift, and they've got diabetes that can have its own challenges, or for example, a job that's perhaps a bit more physical than what they were doing before. Okay, Salman, thanks. So the first case involves a 75-year-old gentleman attending primary care 1 month before Ramadan starts and requiring some advice. They've got past medical history of hypertension and type 2 diabetes, and that's diabetes mellitus, and they're on some medication, probably fairly common medication people are familiar with in terms of when it comes to cardiometabolic disease. Blood pressure is reasonable and has been generally been okay in the run up to Ramadan, and H1C is not is not too bad at all. And they fasted last Ramadan with no issues. So as someone mentioned, we try and get the previous experiences as well to help factor things. So I guess the first question that they'll be expecting you to advise on is, how would you manage me and what would you advise me? So obviously this is not quite an interactive session, but I want you to just think about some of the things going on in terms of the conditions, the medications, the current level of treatment that they're on. If you want to go to the next slide, please. So we'd go through the compendium and we'd risk stratify the patient based on what would be in the section. Now you could argue that you go to the diabetes section first or you go to the cardiovascular section, look at hypertension. It won't really make a difference because the two sections will in fact incorporate each other because we accept and appreciate polypharmacy and importantly, multimorbidity. Thank you so much. And if we were to look, for example, at the cardiovascular section, we can see that when it comes to stable, sorry, the kind of red has kind of just fallen out of sync and moved things up earlier. Stable hypertension falls in the low risk, low to moderate category, which is as expected. And then next. And when it comes to well-controlled diabetes, again, um, appears in the lifestyle therapy, metformin, Archibald's SGLT2 inhibitor. So both are low risk, and as mentioned, both hypertension is not a macrovascular complication. So don't it's a concomitant cardiovascular risk factor. Thank you. So on these grounds, there's no reason to stop fasting if the individual wishes to fast. But obviously, it's not. That's just a headline. It's about now looking the devil's in the detail. Next. And that means that it's about looking at the timing of medication, the suitability of medication, and that needs to be discussed because no, the timing of the fast and what one eats will be important in terms of that. Non-diuretic hypertensive therapy might be best taken at suhoor, the pre-dawn meal, and diuretics may conversely be taken after the start side of things. Because one thing that we realize is the effect of sleep and change in sleep pattern, particularly at the start of the month and risk to quality, affecting quality of life and sometimes even road traffic accidents. So anything that maximizes sleep quality, particularly as the fast getting shorter, there's more likelihood of sleeping for a few hours after keeping the fast as well. So we need to try and appreciate that side of things. So for each individual, very much depend on their lifestyle when it comes to how they're planning to live and what they're planning to do between, for example, the iftar and the suhoor. Thank you. When it comes to the kind of diabetes drugs and things, I'm just going to elaborate a bit more because it's apparent and evident now that SGLT2 inhibitors and in probably due course glucagon-like receptor, glucagon peptide 1 receptor agonists, GLP-1 receptor agonists, are both going to be drugs used beyond diabetes. And we already know that, for example, with the SGLT2 inhibitors, which are used in cardiac and renal disease as well. And therefore, we need to appreciate how these drugs work and what they're being used for, because they might not be used for glycemic control, but they could be used for other factors, even though they have diabetes, particularly if the renal function has dropped, the eGFR is closer to 30, between 30 and 45. The glycemic effect is minimal, but the sodium effect, i.e. the almost diuretic type effect, will be still there. So you might get a different benefit from the drug. So taking this drug might be best, for example, taking it at the iftar time from that perspective. And that if their sugars are dropping, it might not necessarily be due to the sodium glucose transport inhibitor. If their renal function is dropping, it might be other drugs you have to look at. GLP-1 receptor agonists, again, oral semaglutide in particular, more so than the weekly injection, can be a bit of a challenge because of the bioavailability side of things when you want to be on an empty stomach when you take it, but you also want to delay before subsequent consumption of food. So hopefully it won't be too challenging if they're taking the tablet as soon as they open the fast and take some water. So for example, opening the fast with some Zamzam or some water, and then having something to eat maybe 30 to 60 minutes later after they've prayed. Shouldn't be too difficult because the fast won't be too long but allows for the maximum bioavailability. Now, the challenge is that if you don't have this if you don't maximize the bioavailability, then you might lose some of the benefits of the drug. So you might find either the drug is not working or sugars start rising, for example. So they may then have to looking at other alternatives. I wouldn't advise stopping the medication if it can be avoided because it just makes things a bit more complicated. And likewise, I would have tried to avoid any dose titration going up in the month or starting the medication just at the start of the month because of the side effects that can be quite significant and severe for some individuals. With the weekly medications, less of an issue in terms of when you take it, but obviously when it comes to titrating, we just need to be aware of things. Just moving on. Okay, so important thing is obviously to monitor things in terms of monitoring the blood pressure if they wish to do so, particularly if they're concerned of getting dizzy or a bit low blood pressure, particularly if perhaps they're not drinking as much because they're worried about, for example, getting difficulty in Tarawih when they're taking their diuretic tablets. You need to take a full kind of lifestyle history as well, and obviously documenting things in the notes is important. And obviously, if they get symptomatic, as with any condition, they should make a judgment call either as to whether they should continue fasting if they're already fasting, or to terminate the fast, or equally if they've struggled with some previous fast, whether to continue starting the fast. Okay. And ideally, you want to try and review things before Ramadan. I accept it's difficult given that we are obviously just not quite out of winter, but there can be a lot of pressure. There's flu going around. People might not be able to make it to the doctor. And even, for example, with drugs like metformin, depending on the timing of the meal, the larger meal, which meal is larger, that's why you need to look at the compendium and the associated papers to see what is relevant to my patient in terms of what may or may not need to change. The concept of voluntary fasting and trying things may be of benefit, particularly if a patient may have to make some changes or they started new medication since last year, so they were on the SGLT inhibitor this year but not last year. So the trial fast, we'll touch on this later in terms of how to navigate that side of things. And again, if you are able to see use ease before starting the month or before giving advice, well and good, but I accept sometimes that can be a bit tricky. So again, you may give sick day rule advice saying that if you're feeling more unwell or you're finding your blood pressure is dropping, might be an indication to do blood tests. Then and after Ramadan, if you can perhaps catch up with your patient sooner rather than later, that would be useful because you can document and reflect on how the month went, particularly if there were things that went well or not so well, so that when it comes to next year, things can be visited accordingly. And remember, it might not be the same healthcare professional that sees the patient year on year, so that's why documentation of review is important. Second case, and this is to do with acute illness, a 6-year-old female who attends primary care 2 weeks prior to Ramadan. So almost, say you could say someone attending this week and they're having intermittent diarrhea and vomiting for 3 days. They've already got background of kidney disease, hypertension, and they're on Ramipril as a dose of 5 milligrams once daily. And despite her current symptoms, she wishes to fast when Ramadan starts. So again, what are you going to be thinking about? What are you going to be asking your patient? And what are you going to be subsequently advising your patient? Okay. If the symptoms and residual effects, they may resolve when Ramadan starts, or this may not happen. And that's what you have to do. Each person will be different. It's still 2 weeks, but you know yourself, some individuals take 2 weeks might not be enough. For some people, they might be back functioning within a few days after the presentation. So, someone, thanks. You have to make that judgment call in terms of doing tests or not. Now, some may wish to do use and ease because they perhaps don't see the patient very often and they have no idea what their general function is like. You may wish to monitor blood pressure, do urine tests as well, just to make sure that there's no other concomitant infection. And you can see some results there on the side, which show that the EGFR is probably stable. The potassium is slightly high. And again, sometimes with the challenges of primary care, depending when the sample gets to the lab, you have to factor in the effect of hemolysis as well. So you still need to have your clinical hat on when it comes to looking at results and not forget how you would interpret results ordinarily for an individual with the Ramadan bit aside. Okay. So if you have using these like that, you may wish to follow the patient up. If there's no persisting acute kidney injury in the patient as well, then we'd go to the compendium, go to the chronic disease side of things. And then you may wish to refer them on if they haven't got better and they've got worse. And one of the things that can influence that is the concept of sick day rules as well. Like with SGLT2 inhibitors, ACE inhibitors, some individuals may not follow their sick day rules when it comes to these medication and can actually make themselves more ill by taking medication when you're acutely unwell, and therefore it takes longer to recover. And if they are, for example, in that boat or they haven't recovered, you may have to look at the management of acute illness from in the Ramadan compendium, because not only perhaps they have chronic kidney disease, for example, they may have acute illness that might have exacerbated things, and we have to look at the acute illness on its own merits as well. So in terms of dealing with acute illness, when we had first designed this guidance, we had COVID was a big factor in play, but we also recognize that COVID is not the only condition that makes people unwell. So, looking at the right or the beige arm of the diagram, again, the criteria relating to sick day rules comes into play, and it's about making that judgment call. Now, some things are more obvious than others, and there is no exact black or white right answer. It's about using your clinical judgment as you would with anything, but giving the appropriate worsening advice so that if they are making a positive decision to fast, they don't feel any hesitation or guilt or reluctance to break the fast. And likewise, if the individual, you probably think they're okay fasting, but they don't wish to, you respect patient autonomy. So, assuming there is no acute illness or the acute illness has settled, we go to the Ramadan compendium, we go to the renal section, and we risk stratify accordingly. And as mentioned, you factor in patient's age, frailty, and other factors that may compound or increase risk. And in the CKD section, this individual comes under high risk. Now, you have to accept that when it comes to this guidance, as someone mentioned, is grade for evidence, and some might say, well, actually, it's not too bad, and maybe they could fast because it's only 5 milligrams of ramipril, and I get that. But they have had an acute illness beforehand, so it will also depend on how frail they're feeling as well. So, but if you go with just the fact that it's high risk and that evidence they shouldn't fast, that would be the advice that we're given. This is why we advise, for example, to speak to a trusted religious authority because they might not be happy with that advice. But if you explain to them that you are risk stratified, then you would uh, fall fall into a category that puts your risk higher than you would like it to be, but it's not because they don't want to stop you fasting, they don't want to cause you harm. And this is a subjective assessment, and no one would criticize you for following medical advice. And likewise, if you didn't follow medical advice, as long as you were responsible, no healthcare professional is going to fall out with you, well, hopefully. And you can see from the box that's highlighted, it kind of highlights that patients within the high risk or in that kind of middle category there. So we haven't used the word must, but shouldn't. And that's why, because the word must isn't there and they might still choose to fast, what would you do? How would you navigate that? The guidance says not to fast, and you're finding out the patient wants to fast. So again, document things for medical legal purposes. You've shared your clinical view. Uh, you follow the patient up if you can whilst fasting. And I accept that may not be easy, but at least, for example, they know that they should reach out to us if they are in that circumstance. And again, like I said, discuss things if they're not comfortable with the medical advice. And just someone mentioned we're not there to work against, but work with our esteemed colleagues in the Masajid community who are of religious standing. And again, the sick day rules is paramount. And it's important because one thing you could probably argue is that they fell ill before Ramadan. Did they follow the sick day rules or not? So that gives you an indication as well in terms of how likely are you to follow your advice in Ramadan as well. That could also sway your decision one way or the other. Okay, and the final case is a 49-year-old patient who has stable angina, hyperlipidemia, on fairly standard uh, primary preventative and symptomatic medication. Um, has lansoprazole as well, so probably has a bit of esophageal reflux disease, and just keep this in mind as well. Again, what are you thinking? What are you going to ask, and what are you going to advise? So based on the cardiovascular section, uh, he comes under stable angina, which is suitable to fast. Okay. You can take aspirin after the iftar meal to avoid the gastric irritation. This is important because I mentioned he's already on lansoprazole, and I accept that some patients might not be on aspirin at all if they're on lansoprazole, might be on an alternative antiplatelet as well. But we're covering a scenario which is slightly higher risk just to help so we can think about things in a bit more detail. Switching the ISMN to long-acting modified release and taking after suhoor. So as you know, with standard preparation, you take one tablet and then you take another tablet a few hours later, which you could do potentially with iftar and suhoor, but it's probably better to switch to modified release preparation so to get the maximal benefit when the hours of fasting, when they won't be able to, when you're definitely keen to try and avoid symptoms. And again, the statin and lansoprazole can be taken at iftar or suhoor. And again, looking at the evidence. So whenever we're trying to give advice, we try and use evidence if there is evidence that underpins it, so that we don't just rely on expert opinion. And sometimes the evidence might be sketchy, it might be limited, And we are very clear when we have appraised papers in our review articles, the quality of evidence as well, and how relevant and contextualized it is. So, for example, there might be some studies in some countries which are totally irrelevant to what's going on in the UK, particularly in the summer. And likewise, there could be studies that we have done and undertaken with our healthcare systems, which may not be relevant to patients or individuals who are from parts of the world where they have less access to healthcare and less resource. So when it comes to acute myocardial infarction and post-cardiac surgery, and you might have these patients, for example, who have had this acute insult, uh, what happens to them? They might be higher risk for a period, and then their risk settles down. So again, that's why it's important to look at, take a detailed history and look at the timing of things. So if they have had, for example, an acute insult very close to Ramadan, it may be in best interest to delay things for that year and try making fast up in the winter. And again, for example, we know that 6 weeks it can sometimes be a challenge because of the kind of advice given when it comes to cardiac rehab sessions. So very much you need to know your patient. You need to know what's happened since last Ramadan, but also importantly the weeks running up, particularly if there are concerns about rehabilitation and other factors which may help with convalescence. An important thing as well when it comes to routes and treatments for medication, that GTN spray, for example, although it's going into the mouth, based on kind of scholarly consensus, it would not invalidate the fast. And it's important to appreciate there will be differences of opinion. The BMJ paper is quite good at just helping navigate when it comes to different medications and routes, the things that may or may not invalidate the fast and where minority positions or differing positions may also exist. So sometimes patients can't fast for different reasons that we've highlighted, but it doesn't mean to say that fasting is not on the table at all. Can they fast at a later date or when they're able to, as in make up the fast later. And they can also do other aspects of ibadah which do not involve fasting. So, for example, extra salah, Quran, charity, both the voluntary charity that people may be given, the zakat that they might be paying, and also for those individuals that have a permanent or persistent state of affairs, the fidya. So trial and voluntary fasting is something that we have touched on in a bit of detail in the BMJ paper, and this is to really help prepare individuals, but also give confidence both to healthcare professional and the individual when it comes to Ramadan itself, because you don't know, and there's a lot of theoretical hypotheses that might go on in people's minds. But doing some trial of voluntary fasting in Shaban, in particular in the month before, allows you to kind of test your hypotheses, tweak things, change things, and also give confidence one way or the other whether fasting is something that's on the table or not. And often that period just before Ramadan is also quite useful because the length of days the most similar to the Ramadan, certainly at the start of the month in terms of duration. And also it helps the patient or individual perhaps do a bit of consecutive fasting as well to see whether they're able to do 2 or 3 fasts on a trot and how that's going to be. And generally, you might find that, for example, individuals might feel more comfortable breaking a voluntary fast or ending a voluntary fast rather than an obligatory fast, even though the criteria is the same for both. And I think with the trial and voluntary fasting, it's an art. This is the art where the art of healthcare or art of medicine comes into play. It's not black and white. You must do it this way or do it that way. They might look for specific advice, but again, you can try your best. But I think a lot of it is about using common sense, paying attention to what you're putting in to your body, what's going on, what you're doing. Try and keep a diary, maybe just to diarize things to help you understand yourself as well. And no, anywhere from 3 to 5 fasts may be enough just to do that. We don't want people to tire themselves or exhaust themselves before Ramadan starts. So there is a trade-off, but it might be, for example, that you think, well, this person wouldn't be able to fast at all, but maybe they are able to do maybe some non-consecutive trial fast to see how that goes, because that might be something that they could try and do in a month. Okay. So alternatives to consecutive daily fasting. So specifically to consecutive, meaning I every day fasting. Again, the criteria which come back to terminating fast on an individual basis would be relevant, for example, to whether people would fast consecutively or not. And it may be that they can't do consecutive fasting with the duration being longer, but when the duration gets less than 12 hours, they can. So it may be, for example, that they can uh, fast a few days at a time, take a break, or first fast the first half of the month when the days are shorter for the days get longer, and make the rest up in winter. I think the important thing is that they have, as per the previous slide, they're given proper sick day rule advice, and they have confidence in knowing when to take a break or to hit the pause button. And if there are, for example, individuals who can, for example, do even though a third, two-thirds, half of the month, that's still some engagement that they wouldn't have might been able to do had just been given a binary approach to things, as in your is whether to fast or not. I'm not talking about people's genders here. That's a talk for a different day. It's whether the individuals sometimes they're given advice, oh, you shouldn't fast, and that's a whole month off the table. Whereas what we're trying to say is you can make as much or as much and or do most of the month or that you could have that you can do within your capability without harming yourself. And if you are in a circumstance where you've got perpetual or permanent set of affairs that prevent or debar you from fasting, then it'd be worthwhile having a chat with your trusted religious authority, if you wish, about paying the fidya as an alternative. And the interesting thing with the fidya is I had one patient just the other day who thought that they were in that category, and then they realized that actually no, I can maybe manage a few fasts, and they've already started making up the years of fasts that they hadn't been fasting because they had taken a very lenient approach to things. And you think, well, as people get older, they might get more frail, but actually, you'll be surprised some individuals took a more lenient position, and then they, through the confidence they get from these consultations, they not only are managing able to fast, but they feel a moral or kind of religious responsibility to try and make up the fast that they could have fasted in the past as well, particularly in the winter. Hand you back to someone.
Thanks, Nazim. So we're just coming up to the end now. We're just going to talk you through some of the resources that are here. This is mainly for the sake of the recording, and just so you know, we're not making this up. Here are some papers that Nazim and I have published. As I mentioned, in good, high quality journals. So it's not just our view. This is not just the view of the experts that we've got. These are peer reviewed, internationally reputable, prestigious journals that have accepted the work that we put forward. And so to have international societies, we presented this work in many places. We've also put together patient information leaflets with Diabetes UK, Kidney Research UK, the British Heart Foundation, Blood Cancer UK, as well. So please do take some comfort in knowing that we know what we're talking about here in that. There are some particular useful resources that pertains to diabetes, as we have been highlighting to you that Ramadan and chronic disease is not just about diabetes, but we know that diabetes is of a particular concern, which is why BIMA has worked very closely with Diabetes UK in the last few years to put together some guidance. And these are things that you can give to your patients, send out as text messages or emails, or put on your social media if you wanted to for your patients. So we're just wrapping up now. I wanted to thank everyone that's been involved with the Ramadan Compendium, the reviewers, authors, contributors, everyone, and of course the Ramadan team at BIMA as well. If you have any questions that we haven't been able to answer, and we'll take some questions now. That's the email address that you can contact. And so now we will stop and take some questions. So I'm going to stop sharing so you can see both our faces, hopefully. And we will now go to the chat function and the webinar question and answer. So please, if someone has been chatting away in the text box, please can you submit it as a Q&A just so that we've got that open here in front of us. So I'm just going to start off with now some questions about blood sugars and when to break fast. So someone's asking, and the two questions that are similar, what levels are the patient advised to break the fast by their blood glucose monitoring at home? And someone's also asking what parameters of BMs less than 5 or over 15 to open the fast.
So when it comes to high blood sugars, if you're to look at the IDF-DAR criteria, they probably take a more conservative approach that if sugars are over 17, you break the fast. Now, for many individuals, a sugar of 17 is not a big thing. They might not have control that makes 17 look like an infrequent number. So you have to make a judgment call. I think the main thing with high sugars is the osmotic effects, the hyperglycemia from the hyperglycemia and potential dehydration, particularly if they already have CKD or they might not hydrate themselves. So I with higher sugars, I tend to be a bit more contextualized and I take perhaps a bit more lenient. If someone is normally having pretty tight control and then their sugars go up to 17, that's probably telling you they're probably unwell or something's brewing. So that should make you think in terms of how is this patient and maybe at the very least give some sick day rule advice or say keep an eye on things. Low blood sugars are very easy. You break the fast, you treat that low blood sugar because for two reasons. One is your cognitive function will get affected. And secondly, is from a DVLA perspective, there's a legal requirement as well. So low blood sugar should be treated. It's one of the things that I make a bit of an emphasis on when speaking to patients who have diabetes and are on insulin sulfonylureas, is that are they going to be willing to follow the DVLA guidance? Because if they are, that makes things a lot easier. If they aren't, in many ways, you have to be very clear advising them that no, this is A, against the law, and B, they could lose their license and could also result with criminal conviction if, God forbid, they harm somebody. So blood sugars are very much you got to separate the highs and the lows, and look at your patient as an individual in terms of the treatments that they're on. And equally, um, why are they, if for example they aren't going, if they're running high, they might tighten up their sugar control as well when Ramadan starts because they might eat less or the types of food they eat or the meal types.
A similar question here about blood pressure to fast. And I just, now before you come in on this, I think it's important that, as you answered with the blood sugar question, is that there are very few things that are absolute black and white, that someone has this and they mustn't or must do that, right? Everything has to be individualized to the person. And so often when we have these conversations, that, you need to try and depersonalize sorry, you need to try and personalize your response as much as possible. So it's not just about the one-off. There are going to be very few instances if there's a one-off thing that you need to terminate the fast. A lot of it is going to be about the acclimatization of the individual. So if someone's habitual blood pressure is systolic is 100, it's going to be a very different conversation with someone whose, blood pressure is routinely 180 and a sudden, uh, post Ramadan drop, which can happen with fasting, can lead to issues around dizziness and postural hypertension and falls and so on and so forth. So I think I just wanted the colleagues to get this in their head that try as much as possible to risk stratify the person holistically, thinking about their prior experience, their tolerability of fasting, alternatives to fasting, non-consecutive fasting, etc. Right? Try not to make this a very black and white approach to it. There's a huge amount of color. But Naz, I just wondered if you wanted to comment on the blood pressure question, or if you wanted to add any more
No,
to
I
that.
think that's reasonable. I think you have to look at context. Context is key, as with anything. And it seems to be anything related to BIMA, it's all about the context, some of the things that are labeled towards BIMA and otherwise. Context is key. So, and that's why it's also important that as far as possible, and it can be challenging, is trying to go to a healthcare professional who knows you as well. So if you're meeting somebody for the first time before Ramadan, it might be a bit of a challenge in terms of perhaps particularly if your risk is slightly higher compared to somebody who knows you and knows you as an individual. Now, I accept it might not be easy to get that same person, but if you can, it would help. So all these little things are there. And the reason I'm saying this as well is that it's also to help patients understand and realize that no two healthcare professionals might give the same answer. And there's nothing wrong with that. Take Ramadan out of the picture, you go for any other conditions as well or situations. No, it's not a given that two healthcare professionals will give the exact same answer, but one thing you can hope and trust in is that they'll give you an answer that is valid and appropriate for you, even if it's not the same as the next person's.
Thanks. So I think related to this often is a hot topic. What are your views around fasting while pregnant? That's a question that's come through.
That's a question I should say right back at you, shouldn't I? So there's two ways of looking at it. Historically, I mean, our mothers, our grandmothers, our old they all probably fasted during Ramadan when they were pregnant and didn't think twice about it. And this concept of pregnancy was seen as okay, it's like an altered physiological state as opposed to a disease state. However, we also have evidence to suggest that extreme physiological stress or changes in physiological in like circumstances may adversely impact. So we have to be pragmatic about things, understand and appreciate what the mother is thinking as well, what they might have done in previous pregnancies, and conservative advice in terms of not fasting or terminating the fast than we would if they weren't pregnant. But I think in terms of saying all pregnant mothers shouldn't be fasting, it's not something that I necessarily agree with, purely based on the fact in terms of you go to some parts of the world even now, and these are non-issues. But I think the most important thing is giving sick day rule advice as well, particularly if you're the first pregnancy, first trimester, you've got hyperemesis gravidarum, or you've got other medical conditions. So it shouldn't be overlooked or ignored. And again, you may find what its authority you may go to and what medical staff may advise. No right or wrong answer, but I think important thing with when it comes to pregnancies, appreciate that things can change during pregnancy as well. As long as you have insight in terms of fact things can change quite quickly, and you shouldn't. No one's going to give you a gold medal for suffering through this, then it'll be very much an. Someone do you want to add?
Yes, I was just going to say the compendium does talk about pregnancy, so people do have a look at that, and we recognize it is possibly on the more conservative side because at the time it was written during the pandemic as well. But ultimately, it is an individualized choice. You know, if you are a woman who habitually fasts Mondays and Thursdays, you're going to be in a very different situation to someone who has never fasted before, or someone who is fasting for the first time in that year, and it's the, middle of the summer, and you're not really well prepared for it. Generally speaking, as Nazim said, the data that's there is inconclusive because of the biases in the way the studies are done. They're mainly observational, and let's be honest, so is a lot of Ramadan data, but they haven't necessarily controlled for other factors. So there are some studies that show if you have a high fat diet, that can actually overcome some of the challenges that they see. And the main surrogate marker that they use is birth weight. And then from that, imply whether or not the long-term outcomes of what those children might be. And the first trimester, the concerns, as I mentioned, about nausea and vomiting in pregnancy, but also about embryogenesis as well, around what the fasted state might do to embryogenesis. Um, but ultimately, it's woman's individual choice and one that she must make with whatever she feels most comfortable with. Noting that interventionalists, so medics in particular, but particularly obstetricians, may be more risk averse, and those people that are not in that space may have a different risk appetite. So those would all be conversations that you need to take into account there. But the compendium does try to speak to that. So definitely do look into that. I'm conscious that we've just gone to half past, and I know there's some questions that have come in, so I'm just going to try and quickly finish the ones that we've got, if that's all right. If colleagues do want to do this presentation, you're more than welcome to for the community. We have the Beamer Healthy Ramadan um, campaigns. If you sign up to that on the Beamer website or Beamer social media, or if you're on the Beamer WhatsApp groups, you'll be able to deliver that. So that hopefully will answer that question there. And if people have got risk templates that they want to add for their primary care record system, again, that might be something worth mentioning in some of the Beamer WhatsApp groups, because I believe I have seen someone put one together, but I haven't got one to hand. So if someone does know that, please do share that. Um, I am just looking at a question here about fasting and performance, about indemnity being invalid if you have an error while fasting, which is a lay opinion, not by the providers. If I could just speak to that. So, number one, any evidence that comes out, and again, the evidence, we note that has its limitations. But if you look at road traffic accidents in Ramadan, if you look at A&E attendances in Ramadan, if you look at errors during surgery and so on in Ramadan, none of it seems to be specific for the actual fast itself. It seems to be a lot of the issues to do with the neurocognitive performance issues seem to be due to sleep deprivation or due to the circadian rhythm disruption that is there. By which I mean A&E attendances in Ramadan, they just don't happen during the day, they happen during night. Car crashes don't happen during the day, they happen during night. If you look at Muslim majority populations, that is. Again, when you look at people who are fasting and how quick their reaction times is and so on, it actually gets worse as Ramadan goes on for those individuals who are not using adequate sleep hygiene measures to overcome the sleep deprivation or the relative sleep deprivation that they may be getting. So this would be no different from anyone else coming up to any other performance issues as a result of sleep deprivation for other reasons. So there's no reason why Ramadan fasting should be singled out as for a reason why anyone may have any errors in the line of duty. But it's important that you, as a clinician, or for whatever work that you're doing, you take adequate measures. Make sure that your sleep is prioritized, particularly if you're doing shift work or if that shift work is new to you, or if you're taking on new duties that you haven't taken on before, particularly thinking about the heat stress that you may be having. So if you're having to wear heavy PPE in an ITU, is going to be very different than doing a out of hours GP shift, for example, where you've got a driver taking you places overnight. So these are all factors that you have to take into account. And if you have got concerns, then you do need to have an occupational health review. We've done a whole series of webinars around Ramadan and work, which I'd encourage colleagues to look at with the Society of Occupational Medicine there. But I just want to stress there is no evidence that suggests that Ramadan, in and of itself, i.e., the fact of hunger, the fact of thirst, leads to performance problems. When you and I sleep at night, we break fast in the morning after 6 to 8 hours of sleep, right? Our bodies are used to it, it becomes habitual. Our bodies are able to tolerate this quite happily. The issue is to do with sleep disturbance. Nazim, anything quickly on that point?
No, I think it's hit the nail on the head. It's like, for example, somebody doing night shift, you're more likely to have a mistake or an accident after 4 or 5 night shifts than you would be after your first night shift. And we see this with some of the junior doctors, sadly, and why 7 nights are a thing of the past. So I think the most important thing is everybody knows when Ramadan is, everybody's got timetables. It's like with anything in life, if you prepare for you mitigate risk and you might with things. Just picking up on something, the question about what's the concern about ACE inhibitors or ARBs when fasting. So it's not so much it's not, it doesn't matter if you've got diabetes or not per se, but it's more to do with the fact that these medications, as for example, when you have diarrhea or vomiting or GI illness, the sick day rules. So if there's a concern or risk that you're taking less or you're becoming unwell and you're pushing your body a bit more, that being on no drugs is the safest. But if you're on these drugs, it can obviously tip you more towards becoming more unwell metabolically. And we know, for example, that you might not feel unwell, but your body maybe biochemically starting to show strain. It's not unusual, for example, you've seen somebody who's been on an ACE inhibitor or an ARB block or an ARB, and then they've come in with a viralness or diarrhea, vomiting, and their kidney function is 2, 3 times off their baseline. So that's why sick day rules that exist out with Ramadan are still applicable within Ramadan. If they've got poor glycemic control and they're on ARB or whatever, an ACE inhibitor, then obviously they're going to become more intravascular repeat quicker because of the osmotic diuresis as well.
Thanks. And as I'm just quickly around risk stratification, give red flags in the context of a condition, i.e., what to do with asthma. This would be no different to, your general plans, what to do with, what information do you give to your patients when they're type 1, type 2 diabetic, when you start them on SGLT2, when you start them on a GLP-1, when they're, taking IM hydrocortisone, what information do you give them, etc. There's nothing specific around Ramadan red flags, is there, Nazim?
Not that I'm not that specifically comes to mind. I think the most important thing is not neglecting sick day rule advice that's given. Again, you'd very much need to speak to your GP or your asthma specialist who's reviewing you if you're having any changes in medication just before Ramadan or your asthma is stable. And there is the respiratory section, and we actually have had the respiratory guidance accepted for publication in the European Respiratory DRJ Open Journal. So that should be coming out soon. I think, as with any condition like epilepsy as well, it's about understanding not just the weather of the patient, i.e., what's happening just now, but the climate of the patient, i.e., what's their state like generally speaking, so you can look at things in context.
Great, thank you. I think that's all we have time for. Jazakallah, thank you everyone, and appreciate your patience in staying behind for a bit longer. This will be recorded, so you'll have access to it. Please do get in touch with us, info@britishima.org, if you had any questions, such as wanting to deliver these presentations either for the community or for your colleagues. And also, if you wanted to get involved in Ramadan research, you'll see there's lots of questions that are still unanswered, and so your help will be much appreciated. If you're not a member of BIMA already, you can sign up for free at britishima.org. And if you wanted BIMA to do something again, just get in touch and hopefully we can help. Thank you for me, and thank you from Nazim as well. I hope you all have a good evening. Assalamu alaikum wa rahmatullah.